Hello, everyone. I'm Tom Tillman, a therapeutic endoscopist at UT Southwestern and the director of endoscopy and therapeutic endoscopy at Parkland Memorial Hospital in Dallas, Texas. And I am excited to be here today on behalf of all of our co-authors for this author interview for our study published in GIE titled Evaluating the Impact of Different Biliary Stents for Bile Leak Following Fenestrated Cholecystectomy. We decided to perform this multicenter study looking at our outcomes for bile leaks following a very specific type of cholecystectomy, the fenestrated cholecystectomy. For those unfamiliar, a fenestrated cholecystectomy is a type of subtotal cholecystectomy where the surgeon only removes a part of the gallbladder. Generally, a subtotal cholecystectomy is performed when a surgeon deems complete resection of the gallbladder either too difficult or too dangerous, so instead they only remove a portion of the gallbladder to try to reduce the risk of adverse events such as a common bile duct injury. There are actually two types of subtotal cholecystectomy, fenestrated and reconstituting. Once a subtotal cholecystectomy is performed, the surgeon can either close the remnant gallbladder with sutures or staples, which is a reconstituting cholecystectomy, or the surgeon can leave the remnant gallbladder open, which is a fenestrated cholecystectomy. As you can imagine, an open gallbladder often results in a postoperative bile leak that doesn't resolve on its own, and interventional GI is often involved in the care of these patients as we are asked to perform ERCP with sphincterotomy and stent placement for bile leak management. So, the purpose of this study was to look at bile leaks resulting from this very specific type of subtotal cholecystectomy to see whether there was any difference in bile leak resolution when looking at the different types of stents used for bile leak management. And the reason we wanted to look at the management and resolution rates of this particular type of bile leak is because it's a unique type of bile leak. Often, a bile leak is from a small duct, and the goal is to place a stent to change the pressure gradient and divert flow away from the small leak opening and back towards the duodenum so that the leak can heal. However, in this scenario, there is typically a very large opening in the gallbladder that can lead to a large amount of extravasation noted on ERCP, as noted here. So, it wouldn't be unreasonable to think that perhaps you need a more robust or larger stent, such as a fully covered metal stent, to really divert flow away from that large opening. However, in this type of leak, there is also a smaller cystic duct that the bile must first travel through to get to the large opening. So, that raises the question, do you need a large, robust stent to overcome the large opening in the gallbladder? Or would a smaller plastic stent that can lead to preferential flow to the duodenum instead of the cystic duct suffice? And the answer to this question is very important for this scenario because there are significant pros and cons with each type of stent. Obviously, if we are choosing smaller diameter plastic stents as our first line and they are overall ineffective for this type of leak, then we're putting the patient through repeat procedures and anesthesia, as well as increasing healthcare costs by needing to repeat ERCPs to exchange for covered metal stents down the road. However, if plastic stents perform similarly in resolution rates to that of wider diameter fully covered metal stents, then there are significant cost savings to the healthcare system by utilizing plastic stents on index ERCP rather than fully covered metal stents. Another potential con of a metal stent in this specific scenario is that oftentimes in large bile leaks, the common bile duct is very narrow because it's decompressed from the large leak. Placing a larger covered metal stent within a duct this small for several weeks does not come without its own risks of causing irritation or inflammation or a potential stenosis above the level of the stent, as the stent may be much larger than the duct that it is placed inside. So, this study looked retrospectively at all bile leak cases following fenestrated cholecystectomy over a 6.5 year period across 4 medical centers. We included UT Southwestern, the Dallas VA Medical Center, Minneapolis VA Medical Center, and Ronald Reagan UCLA Medical Center. In total, 145 patients were included in the study, and to date, it is the largest cohort in the literature for this specific patient population. We found that there was no statistically significant difference in bile leak resolution rates following fenestrated cholecystectomy, regardless of the stent diameter, regardless of the stent type, regardless of whether we used plastic versus metal stents, or regardless of what stent length we used. There was also no difference in resolution rates noted when looking at whether the stent was left above or below the cystic duct. So, overall, this study suggests that a simple plastic stent can be used on index ERCP and bile leaks following fenestrated cholecystectomy with similar resolution rates compared to using a fully covered metal stent on index ERCP. This suggests that the cystic duct effectively acts as a bottleneck for flow of bile towards the leak. As long as your stent is able to have more favorable pressure gradient to allow bile flow to the duodenum compared to flow to the cystic duct, then the bile cannot reach the large opening in the gallbladder. The lack of ongoing leak from the gallbladder allows for the fenestrated cholecystectomy to heal with resultant resolution of the leak. Hopefully, if you ever come across a bile leak following a fenestrated cholecystectomy, this study will be of use to you one day. I encourage you to read the full article in gastrointestinal endoscopy and would like to thank GIE for the invitation to discuss our study here today. I would also like to thank all of our co-authors and contributors and give extra special thanks to first author and future GI fellow Ronald Casey Turner for all of his hard work on this project as well. Thank you again and have a great day.